On behalf of Boulder Community Health, I'd like to introduce our speakers, Dr. Dominik Rog and Ann Brexa. Dr. Rog is a board-certified orthopedic surgeon with a subspecialty in hand surgery. After earning his undergraduate degree from Northwestern University, he received his medical degree from the University of Illinois at Chicago College of Medicine. After completing his residency at Loma Linda University Medical Center, Dr. Rog completed a prestigious fellowship at the Christine M. Kleinert Institute for Hand and Microsurgery in Louisville, Kentucky. The institute was the site of the world's first successful hand transplant, and while there, Dr. Rog participated in a successful double hand transplant surgery. Dr. Rog specializes in numerous conditions that affect the upper extremities, from the shoulders to the fingers, and sees patients at Boulder Medical Center's Boulder and Louisville locations. Ann Brexa has 40-plus years of experience as an occupational therapist. She has a broad clinical background providing occupational therapy services for a variety of neurologic and orthopedic diagnoses. For 18 years, she specialized as a hand therapist and continues to enjoy treating the hand and upper extremities. Ann sees patients at Boulder Community Health outpatient rehabilitation,
in-house stroke alert activation, 2 West, room 202, in-house stroke alert activation, room 202.
Sorry for the interruption. That location for Ann, again, is Boulder Community Health Outpatient Rehabilitation in Lafayette. Welcome to tonight's speakers.
Hello, everybody. My name is Dominik Rog. Thank you for giving me this opportunity to speak to you about hand and wrist arthritis this evening. What is arthritis? The term is derived from ancient Greek, and it can be translated as joint inflammation or disease of a joint. There are several types of arthritis. There's osteoarthritis, there's autoimmune arthritis, such as rheumatoid arthritis or psoriatic arthritis. There's crystalline arthritis, such as gout or pseudogout. There's septic arthritis, which is caused by an infection, and there's many more. For the purposes of this talk, we're going to focus only on osteoarthritis. Osteoarthritis is characterized by the breakdown of articular cartilage, also called hyaline cartilage. That's the smooth, translucent covering of the ends of bones at joints. This slide is a histologic slide of a normal articular cartilage and one affected by osteoarthritis. The slide to the left shows you a nice smooth surface, and the slide to the right shows crevasses in the articular cartilage as well as breakdown of the joint. Eventually, the cartilage surface disappears and you get bone-and-bone arthritis.
In-house stroke alert activation, room 202. In-house stroke alert activation, room 202.
Sorry about that interruption. Symptoms of osteoarthritis in hands and wrists include pain, a loss of range of motion, which is commonly called stiffness, joint swelling, deformity in some joints that can cause a change in shape, angulation, or bumps that are caused by bone spurs, which are also called osteophytes. There's also often a loss of grip strength. Most symptoms due to osteoarthritis in hands and wrists can be effectively treated without surgery. Treatments are meant to manage symptoms. They do not reverse arthritis or halt its progression. Types of non-surgical treatments include topical and oral medications, supplements, injections, bracing, hand and occupational therapy, and acupuncture. Medications include those that are both topical and oral. There is a topical anti-inflammatory named diclofenac. Its brand name is Voltaren. There are many other oral anti-inflammatories. Advil and Aleve are well known. There are some other more prescription strength brands such as meloxicam shown here and many others. Tylenol, also known as acetaminophen, can be used for pain relief with arthritis. As far as supplements, there are too many of these for the purposes of this talk. I could probably spend half of the talk on the subject, but I'll list a couple of well-known ones. There's glucosamine and chondroitin, which has been studied for quite some time, and there is some good evidence that it does improve hand pain and function in the setting of specifically hand and wrist arthritis. There's another supplement called curcumin, which is the active ingredient in turmeric. I left a few links on this slide for websites that discuss this to some degree. The arthritis.org website discusses other types of supplements. The ASSH.org website also discusses other hand conditions besides arthritis, and it's centered and it's focused for patients. Corticosteroid injections are commonly used in a non-operative treatment of hand and wrist arthritis. They are commonly called cortisone injections. This is a picture of the chemical structure of cortisone. So what are corticosteroids? These are steroid hormones produced in the adrenal gland, which is above our kidney. Cortisone happens to be one of these naturally occurring hormones. The injected corticosteroids that are used in treatment of arthritis and a lot of other conditions are simply synthetic derivatives of these naturally occurring hormones. Corticosteroids themselves are potent anti-inflammatories, and they decrease pain with arthritis by reducing inflammation in the joint. Their risks include injection site pain, which is short and temporary. Certain kinds can cause injection site skin thinning, and I personally try to avoid those at those locations that are at risk. There are usually minimal systemic side effects, but they can raise blood sugar in diabetics transiently. I included this slide because this is one of the most common questions regarding cortisone injections that I receive in the office. There's a question of, do corticosteroid injections progress or speed up arthritis? I think the jury's still not out on the subject. Some studies show a risk of progression, some do not. I included a slide of a study that is fairly recent, from 2022, I believe, that did not show a dramatic risk of dramatic progression when compared to hyaluronic acid injections. Most of these studies are done in knees, and most of them use radiographs and measure of joint space narrowing in the knee as a surrogate for arthritis progression. I don't think this is necessarily applicable to hand and wrist arthritis because arthritis in the hand and wrist often reaches its end stage of bone and bone arthritis when it becomes significantly symptomatic, and I don't think the question of progression is necessarily relevant here. There are biologics that can be injected. These are platelet-rich plasma, which is your own blood spun down to a certain fraction that's then utilized. I think there's fairly decent for its efficacy in the treatment of knee arthritis. Unfortunately, it's not covered by insurance. It hasn't been well studied in arthritis of the hands and wrists, but I think it does play a role in treatment as an alternative treatment. Stem cells, I believe, are a promising new treatment, but the technology is still in its infancy, and there isn't much clinical long-term research yet. It's also not covered by insurance and can be quite expensive. Hyaluronic acid has been around as a treatment for arthritis since about 1997, when it was FDA approved for knee arthritis. Its use is also called viscose supplementation. It was FDA approved for knee arthritis and still only is, unfortunately, and the use for other joints is not covered by insurance. There aren't that many studies in hands and wrists, but because it is quite effective in knee arthritis, and I believe it can be used for hand and wrist arthritis, I use a type called the Suparts, which comes out to be $109 or $119 per vial. The slide I used is just a stock image from the internet. Synvisc was one of the first ones to be approved, but it's not the one I typically use. Hand therapy, I think, plays a very important role in the non-operative treatment of hand and wrist arthritis. I work with many excellent hand therapists. Hand therapists can be both physical therapists and occupational therapists. They can provide other types of modalities such as ergonomic modifications or evaluations, strategies for activity modification, different exercises, and many other modalities that can be very useful in the treatment of osteoarthritis in the hand. Bracing can be helpful for certain joints. It's not very practical for other joints. There are many off-the-shelf splints that can be purchased online in a drugstore. We have them in the office. Some custom splints can be fabricated by a hand therapist. I'll mention some specifics when I talk about each joint. I'm now going to shift to discussing specific joints and osteoarthritis in those joints. I'm also going to discuss some surgical treatments for each joint, but I want everyone to remember that most arthritis in the hand and wrist can be treated without surgery. So this is the distal interphalangeal joint. It's the joint between the distal phalanx and middle phalanx bone. It's involved in flexion and extension of the fingertip, and as well as the thumb interphalangeal joint, which is flexion extension of the thumb tip. DIP joint arthritis is characterized by a loss of motion or stiffness at that fingertip. It creates very characteristic bone spurs that are called Heberden's nodes, and it's this top picture of the two bumps over the top of that joint. It can sometimes cause an angular deformity, which results in a somewhat bent or crooked appearance of the joint. It's not always painful. I would say it's not often painful. There is a strong genetic contribution, with 48 to 87% being genetically transmitted. So for most people, it's not really a wear and tear. It's basically genetics. I included this slide because this is a common finding with DIP joint arthritis. I know this is not arthritis, this is a mass, but it is, I think, relevant. This is a common mass associated with arthritis of the DIP joint. They're called mucoid cysts. They're called mucus cysts. They're also, I think, called myxoid cysts. They are basically joint fluid that's leaked out of the joint and is visible now right above those bumps. Some of these can occur very close to the nail and cause this characteristic grooving of the nail. And this image over here. Drainage of these cysts unfortunately doesn't work, as the recurrence is quite frequent. They almost always return. Surgical excision can be performed in the office for those that are bothersome, but they are benign and can be left alone as well. Surgical treatments for DIP joint arthritis. The mainstay of treatment is a fusion, also called an arthrodesis. It is basically combining the two ends of the bone to eliminate the joint. It's effective for treatment of pain and will treat an angular deformity, as the joint will not be straight. The downside is that the joint no longer moves. In my experience, patients that get to the point of significant enough symptoms to require fusion usually don't have great motion at that joint at that point, and fusing it is often pretty well tolerated. Another treatment that I utilize is something called a chylectomy. This term is also utilized for treatment of arthritis in the big toe. This basically just involves removing those bone spurs that create the bumps in the finger. It's not as reliable for pain relief because the arthritic joint is still present, but it can be helpful when those large bumps are particularly symptomatic and still preserves motion. Next joint down is the proximal interphalangeal joint. It is the joint between the middle phalanx and proximal phalanx bone. This joint is involved in flexion extension. It has more motion than the DIP joint. And symptoms of PIP joint arthritis are similar to the DIP joint. There is a loss of motion, which has a greater effect on hand function because that joint does move quite a bit more. There are also bone spurs that can develop and appear as bumps, which are called Bouchard's nodes. And angular deformity can occur. This is the top left image, which shows the joint essentially falling off to one side. They may have a genetic contribution, but the arthritis of this joint can also be post-traumatic, such as after a dislocation or other prior trauma or injury. Surgical treatments for PIP joint arthritis include fusion and replacement. My preference for the treatment for arthritis of this joint is replacement, although fusion can provide reliable pain relief. Fusions is more reliable in certain scenarios. Some argue in the index finger because there is more force acting on that joint. This is an image of two different kinds of fusion. The next slide shows images of a replacement. The images to the left are showing an arthritic joint and then a replaced joint next to it. The image to the right is the implant that I actually use for treatment of arthritis in this joint. Most patients can recover the same motion postoperatively as they had preoperatively. Most don't, however, recover more motion than they had before the replacement. Implant survivorship after this procedure is about 90% or so after 10 years. So the next joint down is the metacarpal phalangeal joint. Most people call it the knuckle. It is the joint between the metacarpal head and the proximal phalanx. Flexion extension at this joint is an important component this way, but side-to-side motion, also called adduction and abduction, is also an important motion, and it also provides some rotation. Symptoms of arthritis at this joint do include also loss of motion, and this can both be in flexion and extension. This can include not being able to raise the joint all the way and not being able to flex it down to create a full fist. Bone spurs can occur, but they usually aren't as outwardly visible as in DIP or PIP joint arthritis. It often appears more as the joint being larger or as swelling. There's often pain with grip and with motion of the affected joint. There's usually not too much deformity unless multiple joints in a row are involved. This is not the case with rheumatoid arthritis, which can cause quite a bit of deformity. The arthritis at these joints usually starts at the index finger and moves its way toward the pinky. Surgical treatments for this joint include both replacement and fusion. My preference personally is almost always replacement. Motion at this joint is quite important. There are both silicone and pyrocarbon options. I prefer the silicone joint, which is shown at this top left image. It has the best track record and the best survivability. This is a fairly recent study showing the use of silicone replacements for the MP joint in osteoarthritis with very good 97% long-term survivorship. The thumb metacarpal phalangeal joint is a little different. There is a lot of force acting on the thumb when pinching, and for this reason, replacements are not a great idea at this joint. The treatment of choice here is fusion. The next joint we're going to is now at the border between the hand and the wrist. This is the thumb carpal metacarpal joint. It's also called the basal joint. This is the joint between the thumb metacarpal bone and the trapezium. It is a saddle type joint and it is very mobile. There are several degrees of freedom. It can provide both flexion extension, adduction and adduction in the plane of the palm, as well as rotation. These motions, when they're combined, allow the thumb to perform a motion called opposition, which is the ability to reach the thumb across to the other fingers and to the palm itself. And it's a very important part of hand function. Thumb CMC arthritis can affect up to 11% of men and 33% of women in their 50s and 60s. So it's quite common, and it's one of the most common visit complaints for hand surgeons, and that's certainly true for me. Most presenting complaints are pain at the base of the thumb, and this pain is usually activity related, such as with opening a jar, pulling weeds, anything that requires pinching or gripping. There can often be a gradual change in appearance of the thumb base. The thumb base becomes more prominent over time. The arthritis causes the thumb to pull into the palm this way, so it's called an adduction contracture. Over time, to compensate, the metacarpal phalangeal joint can hyperextend, and it creates a characteristic Z deformity, which is this image to the right here. The bump that's seen is not usually a bone spur, but it's the prominent metacarpal base that's shifted up. There are some specific bracing options for thumb arthritis. There's something called an opponent splint, which I've shown here in the top two images. I believe that this is usually best when made by a hand therapist. These can be custom created or made out of plastic material that can be molded to your thumb. There's something called a neoprene splint. There's several options with these. The bottom left option is one we have in the office. These are flexible, so they allow your thumb to move but provide some support and compression. And there's many off-the-shelf braces available as well. Sometimes this works, sometimes it doesn't. You basically have to find out what works best for you. Surgical treatments for thumb CMC arthritis, I would consider this more of a joint reconstruction rather than a replacement. The essential part of this procedure is something called a trapeziectomy, which is removing the trapezium bone. This eliminates one half of the arthritic surface and thereby removes the pain in the joint. Something to suspend the thumb portion of this is where the different variations exist. This is an image of 3 different kinds. All of these different procedures seem to work equally well. There's a lot of different versions employed by different hand surgeons. My preference is a procedure called a trapeziectomy and suture suspensionplasty. It's utilized by many hand surgeons. It essentially involves tying a tendon called the abductor pollicis longus, abbreviated the APL, to the flexor carpi radialis. When these 2 tendons are tied together, they essentially form a sling or a hammock for that thumb metacarpal base to keep it from sliding down to the next bone. That's what these 2 images are trying to show here. There is another version of the procedure that I term an implant interposition that utilizes a biologic implant that's put in the space to keep the thumb from also dropping down. I utilize that for specific scenarios or for revisions, but it also is something that I utilize. The postoperative protocol for this procedure usually involves the thumb being immobilized in some sort of splint for 8 weeks total. So the thumb and wrist don't move, but the fingers are free. Usually for a week or 2, the thumb is in a plaster splint, and then in the remainder, it is in a custom removable brace made by a hand therapist. I don't utilize a cast during the postoperative protocol for this procedure. A return of pinch and grip strength can be expected at about 4 to 5 months. Pinch strength will often return to the preoperative state, but it will often not return to that of a normal unaffected thumb. There are other surgical treatments, including fusion and replacement. Fusion works well for pain, but it is not my favorite procedure because of the importance of motion of that joint. Replacements haven't done well for this joint in the past. There are 2 FDA approved right now, but it's not my recommendation because the track record hasn't been that great for these implants. Another joint below, this is in the wrist, is abbreviated the STT joint. It's the scaphotrapezial trapezoid joint. It's easier just to say STT. This arthritis most often coexists with thumb CMC arthritis, but it can occur in isolation. That's a bit more rare. Its symptoms are usually a deep pain on the thumb and palm side of the wrist, basically over here. The pain is often worse with activity, as with many other types of arthritis. Treatments for STT arthritis for me almost always include the trapeziectomy treatment that I mentioned earlier because it most often occurs with thumb CMC arthritis. When it occurs in isolation, that joint can be fused, or excision of the top portion of the scaphoid bone can be done as well. Now I'm going to talk a little bit about some of the wrist joints. There are 8 carpal bones. They effectively form 2 joints, the midcarpal and the radiocarpal. There are 2 rows of 4 bones. The top joint is between the top 2 rows, and that's the midcarpal joint. The radiocarpal joint is between the bottom row and the radius and ulnar bone. Its function is flexion extension, radio-ulnar deviation, and a little bit of rotation. And they also combine to create something called a dart thrower motion. Wrist osteoarthritis most commonly occurs as a type of post-traumatic arthritis. The acronyms are SLAC and SNAC arthritis. It is also something often seen with autoimmune and inflammatory arthritis. SLAC and SNAC arthritis occur due to a prior injury in the past. SLAC stands for scapholunate advanced collapse. SNAC stands for scaphoid non-union advanced collapse. SLAC arthritis occurs when a tear of the scapholunate ligament happens, such as with a fall. SNAC arthritis occurs with a break or fracture of the scaphoid bone that is untreated. Unfortunately, this is somewhat common as the scaphoid bone, sometimes when broken, doesn't hurt that much. Patients or people will feel that they just sprained their wrist, and 5, 10, 15 years later, they can develop arthritis there. Arthritis at these joints is characterized by a loss of wrist motion, usually in this direction, flexion extension. There's often pain with activity or increased swelling with activity. Swelling often occurs at this side or part of the wrist. Treatments for arthritis of the midcarpal joint include something called a proximal row carpectomy, which involves removing the 3 bones, the scaphoid, lunate, and triquetrum. And this image here shows a wrist after a proximal row carpectomy, where the joint is now converted into basically a single joint between the capitate and radius. If the capitate head is arthritic, it can also be replaced, as with this image here, and the capitate head is replaced with a metal implant. Another treatment option is something called a scaphoid excision and 4-corner fusion, where the scaphoid is excised, and then these 4 bones here are fused, again transforming the wrist into a single joint. Both techniques, because they eliminate one of the joints in the wrist, lose about 50% of wrist motion. So instead of going all the way this way, the wrist motion is about half or so. There are some alternatives to a fusion or a proximal row carpectomy. There are 2 nerves that run in the middle of the forearm, right in this area, that only innervate the wrist joint. At this point, their only function is transmitting pain and proprioceptive information to the brain. They innervate about 40 or 50% of pain signals from the wrist joint. If these 2 nerves are cut or ablated, then 50% of wrist pain can be eliminated, which basically buys time. The arthritis doesn't disappear, but the motion in the wrist can be preserved with less pain. In addition to the denervation, a wrist arthroscopy can be added to shave away part of the radius bone to take away some of the arthritic surface. I would consider this a viable procedure for mild arthritis and something to buy time without sacrificing wrist motion. These 2 surgical treatments, total wrist fusion or total wrist arthroplasty, generally exist for more advanced arthritis of the wrist. Usually the entire wrist has to be involved to consider these treatments. Many times they are utilized as salvage procedures after some of the procedures, as I mentioned earlier, haven't worked. Total wrist arthroplasty is very similar to a hip or knee replacement, where the joint is again changed into a single joint with metal and plastic implants. And now we're going to invite Anne to talk a little bit about some hand and wrist exercises.
Thank you, Dr. Rog. I'm Ann Brexa. I'm a hand therapist, and I was invited to teach you some basic exercises for prevention and promotion of good range of motion of the hand. Before I start, I wanted to say that hand therapists work very closely with the hand surgeons in the treatment of arthritis. Much of our treatment as hand therapists are people complaining of pain in their hands. Probably the largest percentage of people that we see for evaluation and treatment are coming in with arthritis. And it can be early onset pain, weakness, changes in joint status, and or advanced arthritis. My goal is to provide you with some exercises that you might introduce early on and perhaps achieve some prevention. In addition to exercise, hand therapists do a full evaluation of the hand and upper extremity and determine where the origin of the problem exists. The exercises I'm going to do today are pretty general and not specific to a particular form of arthritis, but just general exercises that most people could do even prior to developing arthritis. In addition to exercise, we do have recommendations for splinting, which Dr. Rog talked about, and splinting prevents further advancement and protects the joint and allows for improved function if you have arthritis. We also talk about modalities such as using heat, which could be a moist hot pack, a paraffin bath, or one of those rice bags. And moist heat helps prevent pain and helps promote mobility. We also talk about joint protection, which is learning how to use your hands in a way that reduces the impact of wear and tear on the smaller joints of the hand. And then we talk a lot about adaptive equipment, which I'm sure a lot of people are seeing on the market these days, such as large grip handles, pencil grips with increased size, etc. If you come see us, we'll give you a lot more information in that area. Now I'm going to start with exercises for the hand and wrist. And first, I'd like to start with the larger joint with the wrist. You can do these with me if you'd like. The first one is just wrist flexion and wrist extension. And all we're doing is maintaining mobility of the wrists in the two primary movements that we use them in. So here's wrist extension. I like to do these with the elbows extended and the shoulders back and down. So wrists up, this is wrist extension, hold for 5 seconds, and then wrist flexion, bend forward for 5 seconds. You can do these 10 times, and you can do them throughout the course of the day. The next exercise is wrist circles, and these promote just loose fluid movement of the wrist joint. And you can just place your elbows in a relaxed position, shoulders relaxed, and just gently let your wrists circle in a fluid motion. And then you can let them circle in the opposite direction. 10 times, do them periodically throughout the day. The next exercise is to promote stretching of the fingers. Dr. Rog talked about the different joints of the finger, the distal joint, the proximal joint, and then the metacarpal joint here. And those joints all need to be mobilized as well. What we say about exercise is motion is lotion. The joints become stiff, and the synovial fluid that lubricates the joints is often becomes restricted. So we want to keep those joints moving in order to lubricate them. So the finger stretches, if you put your hands flat on the table, my table is I can't think of the word, fabricated. So finger stretches, open your fingers and spread them apart as far as you can. Hold for a few seconds and then bring them back together gently. You don't have to use a lot of force. Movement should be natural and fluid, not forceful. Spread those fingers apart. Bring them back together. And you'll do that 10 times. The next exercise, palm on the table, is finger extension. This exercise is working on the metacarpal joint, those big knuckles. With your hands flat on the table, you're just going to lift up each digit, one joint or one finger at a time. Let's start with the thumb. Thumb up, hold, thumb down. Index finger up, hold, and down. Middle finger up, hold, and down. Ring finger, the last 2 digits are a little trickier because they have co-joint tendons, so you can bring those up together and back down. And you can do that 10 times. The next one is that thumb joint, the carpal metacarpal joint that Dr. Rog talked about. It's probably the most vulnerable to arthritis. These are our tools. This is how we manipulate the world. And these joints get wear and tear. And the thumb joint is one that we really need to pay close attention to. So with your palms on the table, gently slide your thumb out as far as you can, hold it, and then bring it slowly back in, and you'll do that 10 times. Slide that thumb out, slide it back in. You are mobilizing the carpal metacarpal joint. Next, we're going to do an exercise that promotes opposition, bringing that thumb out and stable, and it's the C position. So with your hands, you're just going to bring your hands into a C position. With advanced arthritis, that thumb collapses and it's difficult to do. So we're going to prevent that by positioning our hands in a C, nice curved functional position, and then straighten. Move into that C position. Make sure that C is nice and rounded, and straighten. Okay, and then one to just carry that on a little further is the O position. And again, a lot of times as that joint collapses, it's hard to make an O and the thumb flattens out. So let's focus on round, straighten. Try to make a nice round O and straighten. Okay, the next exercise is again to support and promote range of motion in that thumb and the CMC joint. I call this the joystick position. Put your hand in a gentle fist, rest it on the tabletop, and with your opposite hand, you're going to stretch that thumb back and hold. It's gentle, it's supportive, and it's firm. You're not yanking on it, but you're improving the range of motion and maintaining it if you have full range of motion. Back down, lift the thumb up, hold the joystick, and open it. Okay, you can do that exercise 10 times. The next one is called thumb rolls, and this exercise is subtle. And it's important for maintaining that ability for the thumb to roll and oppose over. Palms on the table, gentle fist. Take your thumb and you just are gently rolling it from the base. Subtle. And that's maintaining the mobility of the MP joint and the CMC joint of the thumb. Almost finished here. The next one, again, is promoting prime movement of the thumb. I call these pinky slides. Bring your thumb out, bring your thumb over to the tip of the pinky if you can get it there, and then gently slide it down the full extent of the pinky to the base. Hold it for a moment and then stretch it back out. Repeat that sequence. Thumb over to the pinky, slide down, open up that carpal metacarpal joint, hold 10 times. And lastly, these exercises, by the way, are all purely for range of motion. They are not for strengthening. That's another set of exercises, but I'm just here to show you range of motion exercises today. This next one is a nice way to promote the natural curve and hand position for functional use of your hand. You can take a tennis ball, place it in the palm of your hand, bring that thumb out. You don't want it close to your index finger. You're going to bring it out into a comfortable position, and it's just a gentle compression against the ball. You don't need to squeeze hard. Hold 5-10 seconds. Engage that thumb, engage the fingers. and relax. And you can repeat that sequence as well. And that wraps up some range of motion exercises for your hands.
Thank you, Dr. Brexa. We're going to bring Doctor up here as well, Dr. Rog. And then we wanted to let our audience know that now is the time for Q&A. And if you have some questions, please put it in the chat box below the video, and we'll get to as many as we can. And in no particular order, we're just going to start with some questions. Why is there shooting electrical light pains that go from the bottom of my wrist into my thumb? The shocks stay for a few seconds.
I'll take this one.
Please.
Sure. That is more than likely not a symptom of arthritis, or rather it sounds to me like a symptom of a nerve compression. There is something called carpal tunnel syndrome that can affect a lot of people, and it's a compression of a nerve here in the wrist, and it innervates the thumb, index finger, middle finger, and part of your ring finger, and it can cause a electric type sensation in the thumb. Pain can also radiate, so you can, if you have arthritis in your thumb, it can cause pain to radiate up. But if you describe it as an electric type pain, that to me sounds a little bit more like a nerve compression phenomenon.
Okay, thank you for that clarification. Would reducing consumption of dairy products help reduce arthritis inflammation?
I don't think I'm enough of a nutritionist to answer that one accurately. I think there's a lot being written and talked about an anti-inflammatory diet, and I think there's certainly something to that in decreasing systemic inflammation to hopefully allow for relief of arthritis. But as far as the specifics of which foods to avoid and which foods to include, I don't have enough knowledge about the specifics of that to tell you. But I think exploring an anti-inflammatory diet would be a good option.
And so that would be with a nutritionist?
I think a nutritionist would be a good person to start with. I think there's a lot of resources on the internet as well on the subject.
Okay, thank you.
I would agree.
Yeah, there's a lot of stuff out there.
How can I tell if what I have is arthritis or just a strained tendon?
A strained tendon can cause similar symptoms to arthritis. This is part of the question I answer when patients come to see me is, what is my pain? For example, a tendon, I'll choose an example of the thumb. A tendon can be strained here in the wrist. It causes inflammation, and it has a name. It's called de Quervain's tenosynovitis. Now, that location is quite close to the thumb, but they are quite distinct. So if your pain is here, then I think it's a strained or inflamed tendon. If your pain is mainly in the thumb base with gripping or twisting, then it's probably more arthritis. But as a general question, I think that's a little difficult to answer because sometimes they can certainly overlap.
Okay.
I would add also that sometimes in the clinic, we do provocative tests that are governed towards different diagnoses. So we can do a particular test to determine if that is symptom-free, then it might not be arthritis. If you have symptoms with a test that's more related to the tendon, then that will give us a little bit more specific information.
Okay, thank you.
Mm-hmm.
Why is my arthritis pain worse after sleeping?
That's a great question. I think a lot of symptoms of stiffness can be worse in the morning. And mentioned the joint lubrication job of synovial fluid. So if you have bone and bone arthritis and you have no synovial fluid there, moving it around during the day lets that fluid coat the joints. If your joint has been stationary for hours while sleeping, that joint is no longer lubricated. You start to move it in the morning, everything hurts and feels stiff.
I find also that people generally complain that sometimes they have more swelling in their joints at night, and partially is they're not moving. Without knowing what your particular complaint is relative to your hands. Sometimes we wear compression gloves at night, and that helps, keep some of the swelling from forming and alleviates a little bit of that stiffness, but it's specific to your particular condition.
Is there anything that you should do in the morning then for that condition?
I think warming the hand up really helps with joint motion.
Mm-hmm.
So warm water, I think, can help, or in the shower, and just getting them moving.
And then back to those range of motion exercises, movement is universally beneficial for most joints.
Okay. Can trigger finger get better without surgery?
Yes, with the first line treatment for trigger finger is, at least in my hands, an injection, and I think for a majority of cases it can be cured with corticosteroid injection. I think hand therapy has a role in it too, but yes, I think it can certainly be treated without surgery.
Okay.
And as a hand therapist, I've seen great results from people getting involved in early intervention. We do splinting as well to try to rest the joint, and then isolated controlled exercises, and then determining what the provocative activity is that might be contributing to it and changing your approach to your activity.
Okay. This person takes steroids daily and has osteoporosis. Would this greatly impair recovery after having surgery?
That might be difficult to answer as a general question, but I think for the most part, no. Osteoporosis is a little different than obviously osteoarthritis. It has to do with the density of bone. However, that density of bone to begin with is usually lowest in something called the metaphyseal bone, which is that bone right below the joint, and that's where osteoporosis can often affect a bone. And I think it can certainly affect joint replacement surgeries with larger joints. I don't think it's a huge issue for many of the surgeries I mentioned and when speaking about the specific finger joints.
Okay. This is a fairly specific question for this one of our participants here. They had CMC arthroplasty with tightrope 3 months ago on one hand, needing to have the same on the other, but actually would like to avoid surgery. Any suggestions? They say that their recovery has been tough with a lot of stiffness and pain.
I would certainly try all the modalities or options I mentioned in the first 10 minutes of the presentation. Try an injection. If a cortisone injection hasn't worked, you can explore hyaluronic acid. You can explore PRP even. You can explore custom bracing made by a hand therapist. If there's something on that list I mentioned you haven't tried, then try it. Perhaps it will work and it'll help prevent an operation. Another point I'd like to make is that severe CMC arthritis can often be asymptomatic. I see that more often in the elderly population, but the severity on visually and on x-rays doesn't always correlate to the pain that you get. So sometimes people can have a severe arthritis without pain, and I think at some point they figure out how to live with it, and that's where a hand therapist, that's where all these modalities that I mentioned fit in. So I would just try everything on that list that you can.
And I would put a plug in that it might not be a bad idea if they have not seen a hand therapist. Sometimes being guided or accompanied by a set of hands and eyes on your particular condition could be helpful rather than kind of trying to figure it out on your own. And you could do that with an evaluation and not a long course of therapy.
Okay. Can you clarify, they had asked about PT, but you're an OT, occupational therapist. Can you tell us the difference in what you recommend for people? Maybe if they should just go to you as an OT?
Well, the more specific than OT and PT, traditionally occupational therapists tend to advance their study into the field of hand and upper extremity therapy. PTs can become hand and upper certified hand therapists as well, but the vast bulk of therapists, I would say, are OTs. More importantly than PT versus OT, I think you would want to work with somebody who's a certified hand therapist so that they have the credentials of CHT, and that is an advanced course of study that's specific to hand and upper extremity challenges.
Thank you for that clarification. How long do the replacement joints and implants last?
Depends on the specific joint. The metacarpophalangeal joint that I mentioned, the paper I cited showed a 97% survivorship, and they just mentioned it as long-term survival because they had a range of, I think, like 5 to 17 years, because it depends on when patients drop off in the study. But that was, I think, I would call it 10 to 15 years or so. This might be going too much into the specifics of the subject, but silicone replacements aren't like metal and plastic replacements. They aren't anatomic recreations of the joint. They are basically just fillers of the joint. They just create an interposition, and your body creates almost like a scar covering around it. So they do not function like an anatomic joint, and for that reason, even if they break radiographically, they still work to alleviate pain. So as far as the joint lasting, many of them may last forever because they've performed their duty of alleviating pain. Even if you look at an x-ray and it might look a little off and perhaps is broken, it doesn't really affect the end outcome.
Okay. Do you treat hand psoriatic arthritis, and how?
I do. It depends on the specifics of which joint is affected. I work very closely with rheumatologists because they are the main. They're going to provide the mainstay of treatment of psoriatic arthritis, which luckily these days includes very good medications such as biologics that prevent the destruction of the joint that autoimmune arthritis causes. I would say as far as how it is, depends on which joint is involved. I know that the presentation was focused on osteoarthritis, but if a PIP joint is involved due to psoriatic arthritis or a DIP joint, everything I mentioned is still relevant. The joints would be treated that way, or with hand therapy, or with bracing, or with anti-inflammatories. What's different with autoimmune arthritis is that there's a whole separate portion of treatment which involves medications that keep the immune system from affecting that joint and destroying it.
But we would follow, in hand therapy, we would follow the same principles of addressing joint challenges like joint protection, maintaining range of motion, modifying activity, and retaining function.
This person asked, should I keep my arthritic thumb joints active or minimize activity?
I think it would be difficult to minimize activity of your thumb. It's pretty crucial for everyday function. So I would argue use it as much as you can. If there are particular activities that really irritate the arthritis, I would maybe avoid those or find alternative workarounds. But I wouldn't stop using your thumb. I think that's an important part of your function.
We do address, to complement what Dr. Rog is saying, we do address options. So as opposed to using your thumb all the time, if you have to lift something up in this position, you could instead take your thumbs out of the equation for a more challenging activity and just use two hands. So there's a lot of tips that we provide for joint protection and alternative ways to use your hand, but maintaining your range of motion and thumb function is really important.
Can arthritis ever go away?
I think the short answer is no, but the symptoms can. So the arthritis will be there, but it may not hurt anymore.
Okay. Just 1 second. This person plays guitar in a band. They have regular shows. The left-hand ring finger can really be bothersome. Any exercise or medication suggestions? They're 66 years old.
I'll let Ann help with this one too, but I think it would depend on what's going on with the ring finger. I think there's there are many overuse injuries in musicians that may have nothing to do with arthritis, so it would really depend on what is involved in that ring finger that's bothering this caller, this viewer. If it is arthritis, I mean, all the things we talked about, but you can have tendinitis. You can have just something as a basic term of overuse pain, which is pain from just doing the same repetitive motion thousands of times. And hand therapy actually happens to be very helpful for that.
I would say if there's a problem that's persistent and you've tried your own home strategies and the problem does not resolve, and particularly playing the guitar is a repetitive motion, kind of overuse activity, just to support the industry that we're in, we're an excellent resource to come in and have an evaluation, and we can better determine what the problem is and guide you in ways to continue to promote your participation in a really important activity, but give you alternatives to protect your finger and maybe help it recover so you can still do that. Sometimes it's hard to figure it out on your own, and we're available to help you with our knowledge pool.
I agree. Sometimes the answer is complicated. Sometimes the answer is simple. If you have pain arising from arthritis from a joint, an injection can often help with a lot of that. And if that's if that keeps you playing the guitar, it may be a simple solution.
Okay. We are going to do a few more questions here, but we may not get to all of them. And just to remind our audience that if we don't get to your question, that they can be emailed to pr@bch.org. How does the change in barometric pressure affect arthritis and why?
That's a great question. I'm not sure anybody really knows the answer to that. I would say I don't think it affects the outcome of arthritis or its progression. I think it affects the perception of symptoms, though. So I think a lot of people do describe an increase in pain or symptoms with changes in barometric pressure. I think that's been described and heard enough by enough people that's got to be real, but nobody really knows exactly why that happens.
Or anything to do about it?
I don't think there's much to do about it, unfortunately.
Yeah, I think we just acknowledge that, it's a barometric day, and continue doing your essential exercises. You really can't harm yourself on a day where there's high barometric pressure, I would say.
Yeah, I agree.
Thank you. Is Voltaren recommended, and is there a better analgesic?
I advocate trying it. I think I don't have any preference for brands. Voltaren just happens to be one of the brands of topical diclofenac gel. There is a generic version. I think it's certainly worth a try. I think sometimes if your arthritis is advanced enough, it won't work. But if you have mild arthritis, especially in joints where that topical medication doesn't have that much to basically get into or soak into, I think it is a worthwhile treatment to try for decreasing inflammation.
Okay. Any supplements that can be taken or done to slow arthritis?
I think if somebody thinks of a supplement to slow arthritis, they will be extremely rich. So I don't think anything has been proven to really slow the progression or halt the progression of arthritis, unless you know some secrets.
No, it's out of my wheelhouse when my patients ask me that. That's not my forte, but I think supplements have a role in our lives. I just can't speak to the efficacy of them.
Okay. So the exercises that you showed, if it hurts to do them, do they continue to do them?
Good question. There's that adage, no pain, no gain. Or the other adage is no pain, keep it at no pain. What I say is when you're starting movement, there may be a little bit of soreness. And I think, again, it's helpful to be guided through some of these. If you're just trying something on your own and you're having ongoing pain that lasts longer than maybe 60 minutes, that's kind of a sign that you should lay off that activity. But when we initiate movement, there may be a little bit of soreness, and subjectively, I say try to move through it and try to find some comfort, because sometimes after a few repetitions, that pain starts to subside. There's an element of subjectivity to that, but minimal pain is preferable.
Okay. My fingers and thumb often lock. Is that a symptom of arthritis or another condition?
Again, that's, I think, something I would have to see to be able to give a clear answer for specifically. There's types of locking that are not arthritis. There's a condition that's very common that Ann sees and I see a lot of. It's called trigger finger, and that causes a snapping appearance of a finger, and that is actually a tendon entrapment. There is an entity where a tendon over the top of the hand can slip over the top of the metacarpophalangeal joint and cause a finger to be stuck straight, bent, so you have to straighten it out. That causes a locking sensation. That is also not an arthritis problem. There is a significant component of instability of the thumb CMC joint when arthritis happens there. It starts to move around more, and if the locking or sensation happens there, that could be a symptom of arthritis. But there's a lot of things that can there's a lot of locking that can be a symptom of arthritis, and there's a lot of other things that can cause it as well that are not arthritic.
All right. For the last question, can you still type and return to work after trapeziectomy and suture suspensionplasty? How long would you take off work? This person does computer work every day.
The first answer to the question is yes, you certainly can go back and type. The return to work is a little longer for physical jobs where your job involves a lot of gripping and lifting, but luckily something like working on a computer you can certainly return to. It would depend on your demands and volume. I mean, I've had patients return even with the splint on. They have to modify how they type. They can't type with their thumb. They have to kind of hold their hand in a funny position and type with their fingers, but it still can be done. I mean, that could be returned within that 8-week period. I would say to return where you just can do things naturally and without thinking about your thumb, that would probably be more 3 months or so. But to return to typing, you can do that a lot sooner if you modify how you're doing it.
And the OT can help with that?
Certainly.
Definitely. The goal of Dr. Rog's surgery and then the follow-up hand therapy is about restoring function. And our hope and expectation is for you to be able to participate in almost all of the activities that you were doing prior. What we talk about is maybe modifying the activity, using supports, using different types of equipment, but always with the intention of getting back to the task that is part of your life function.
Thank you so much for your time tonight, and also to the audience for all your great questions.